Hi everyone, thank you for joining us. It's my pleasure today to welcome Dr. Nicole Tolan, Assistant Professor of Pathology at Harvard Medical School and a Medical Director of Clinical Chemistry, Point of Care Testing, Mass Spectrometry, and Healthcare at Home at Brigham and Women's Hospital. Nicole, welcome and thank you for joining us today.
Thanks for having me, Joe.
So to begin, which is very relevant to your last title, I know you wear many hats, but today we're going to focus on healthcare at home, which is pretty unique. So what is healthcare at home?
So there's been an initiative at a couple of institutions within our healthcare delivery network system, so across both Brigham and Women's Hospital as well as Massachusetts General Hospital in Boston, to help to alleviate some of our patient throughput issues in the hospital. So many people are aware of the skilled nursing facilities kind of at home, like there's an umbrella, I think, of care that we can deliver in the home, one of which is perhaps what we call our home care system, which is more synonymous with skilled nursing facilities helping patients through certain conditions at home. But what we're really focusing on now is to be able to deliver more acute type care. So these are patients who come into the emergency department and instead of getting admitted to an inpatient bed, they're stable enough that we can actually, as long as they're within an acceptable radius of the hospital, response time, we can actually transition care to their home, see the benefits of having home-based care as opposed to waiting in the ED to get an inpatient bed. So these patients are a little different in terms of their acuity, their conditions that they're really being treated for than what you typically would see with, skilled nursing facility type approach at home.
And what is your role as a laboratory director overseeing that? And what role perhaps would the clinical laboratory have in delivering that care?
Yeah, so I was asked to kind of help take this on. We've transitioned away from a particular device that originally had a waived status to now having a moderate complexity status. And there are certain things that come along with that additional complexity in terms of validation, in terms of 6-month cross-checks, linearities. So, I think we're holistically looking at how do we support really point of care testing at remote sites at these patients' homes using more complex methods than had been able to be used in previously. So, my role is really to help shepherd that work. Having had years of experience in point of care testing, we're now just shifting the model a bit. There's other factors that come into consideration, both in terms of who's delivering that care, who's performing tests. Right now, a predominant number of our healthcare providers are paramedics. And we're working then to increase the bed capacity at these patients' homes with nurses. So, my role is to really help to implement this point of care testing at these patients' homes and take into consideration, transport, time, temperature, how do we store the reagents? How do we ensure quality around those reagents? It takes IQCP to like a whole new level thinking about all of these factors. And so, then there's all the other components of remote connectivity, because as of right now, and historically, the results have been manually transcribed into the medical record, which is what it is, but it's not what we want. And so now we're working to try to sort out with the support of informatics systems to really have a full kind of encompassing point of care program to support this home hospital initiative.
So in addition to some of the challenges that you've obviously faced in implementing this, what are some key differences that you see between this implementation of this type of point of care versus point of care in the hospital? What are some of the main challenges you've seen?
Yeah, I would say those things about being remote. So in the hospital, we have very good control. We have a refrigerator, we have a continuous thermometer that's measuring the temperature, the storage of those reagents in the hospital. If not, you have someone going in and doing a min-max thermometer and checking the temperature, daily to confirm that the reagents are stored appropriately. We don't really have that when you're talking about paramedics or nurses or other advanced practice providers taking a point of care test to and from their car into the home. Cartridges, they may have picked up at a local kind of storage facility and then taken with them during their day. So I think that is the piece that's really requires much more attention to detail to ensure the quality of those patient test results that we're taking, we almost take for granted, I think, in the hospital.
And it sounds like the regulatory space on that side is completely empty, right? There is no specific regulatory or guidelines that govern such an initiative, right? I haven't heard anything like that in lab that you could go to if you're looking to implement such.
I'm not really familiar with that. I think, a lot of the guidelines and recommendations are born out of the same kind of point of care testing. And then I think using the IQCP for what it was intended to look at these areas of risk is really how we're approaching this. But yeah, as far as I'm aware right now, I don't think that there's any particular guidelines established for this type of remote care.
And what are some of the main drivers for implementing such an initiative?
So, I think right now we have a census of maybe 70 beds, remote beds at patients' homes. And we're looking to scale this up to 200 plus beds. This is equivalent to the size of a smaller community hospital within our network. And this is really, I think going to be more prevalent in hospitals to deliver care when they're faced with these types of patient throughput. We do have very high number of boarders in the ED, patients who have gone through the ED and they're not needing ED kind of care. They're ready to get admitted to the inpatient floor, but we don't have the throughput or capacity to find them a bed right away. And so this helps to decant some of those patient workflows, take some of the stress off of all of the healthcare providers in this space. And also there are a number of huge benefits for patients to receive care in their own home as opposed to in the hospital setting.
So as a new territory for any labs or hospitals interested in pursuing similar initiatives, do you have any recommendations from your experience that you'd share?
Yeah, my recommendations would be to understand the entire testing process. I mean, really to look through the whole process of IQCP to understand where are these risks. And then to make sure that you're testing scenarios that are complementary or similar, as close as you can to what's really going to be happening in the patient's home. Us doing a laboratory-based validation on residual waste lithium heparin syringes off of blood gases is not going to really reflect the same type of testing that's going to be done in the home, finger sticks or other things like that. We did notice that there was an increased inaccuracy when we were doing finger sticks for PT-INR testing as opposed to a venipuncture. And so this is one example where you really have to consider the entire testing process, and maybe that's not recommended if you really need to be more accurate in that type of test result. Really, the venipuncture may be what we need to be doing.
Excellent. Well, Dr. Nicole Tolan, thank you for sharing your expertise with us, and thank you all for watching.
Thanks for having me, Joe.